HAMMERTOE is an orthopedic disease condition. Look at this picture shows that an X-ray findings. Look at this hammer shape of toes. A detail going on. Introduction. HAMMERTOE is a common deformity of the toe joints, primarily affecting the second, third, or fourth toe. It occurs when the toe becomes bent at one or more joints, resembling a hammer. This deformity can lead to pain, difficulty walking, and corns or calluses. Hammertoe is often progressive or worsens over time. Definition. Hammertoe is a deformity of the toe, typically affecting the second, third, or fourth toe, where the middle joint bends downward, giving the toe a hammer like appearance. It results from an imbalance in the muscle, tendons, or ligaments that normally keep the toe straight. Etymology. The term hammer toe originates from the resemblance of the affected toe to the shape of a hammer due to its bent downward position at the middle joint. The word is derived from Old English hammer, hammer, and to toe, highlighting the toe's hammer like appearance. Epidemiology. HAMMERTOE is a common foot deformity affecting approximately 2 to 20% of the general population, with higher prevalence in older adults and females due to footwear choices and age related muscle imbalance. The condition is also more frequently observed in individuals with diabetes, arthritis, or neuromuscular disorders. Types. 1. Flexible hammer toe. Early stage toe can still be manually straightened. Less severe, often treated non-surgically. 2. Rigid hammer toe. Advanced stage toe is fixed in a bent position, usually requires surgical correction. 3. Claw toe. Related, involves all joints of the toe curling downward, commonly associated with neurological disorders. 4. Mallet toe. Related, affects the distal joint of the toe only. Causes: 1. Muscle imbalance between the flexor and extensor tendons. 2. Prolonged wearing of ill-fitting shoes, example high heels, tight shoes. 3. Genetics, inherited foot structure. 4. Toe injury or trauma. 5. Arthritis, especially rheumatoid. 6. Diabetes with neuropathy. 7. Stroke or neuromuscular disorders. Example Charcot-Marie-Tooth disease. Risk factors: 1. Age, more common in older adults. 2. Female gender due to footwear choices. 3. Footwear with narrow toe boxes. 4. Flat feet or high arches. 5. Family history. 6. Chronic diseases, example diabetes, arthritis. 7. Poor foot hygiene and neglect. Complications: 1. Pain when wearing shoes or walking. 2. Crohn's and calluses. 3. Ulcers, especially in diabetics. 4. Joint stiffness or immobility. 5. Balance and gait disturbances. 6. Secondary infections. 7. Emotional distress or embarrassment due to appearance. Pathophysiology. Pathophysiology of hammer-toe step-by-step process. 1. Muscle tendon imbalance begins. There is an imbalance between the flexor pull down and extensor pull up muscles of the toe. This imbalance can result from poor footwear, trauma, or neuromuscular disorders. 2. Increased pull on flexor tendons. The flexor tendons, especially flexor digitorum longus and brevis, begins to overpower the extensors. The toe starts to bend at the proximal interphalangeal PIP joint, causing the hammer shape. 3. Joint misalignment develops. As the toe remains in a flexed position, the PIP joint becomes misaligned. The metatarsophalangeal MTP joint may hyperextend to compensate, worsening the deformity. 4. Soft tissue tightening and contracture. Tendon, ligaments, and joint capsules begin to contract and shorten, fixing the toe in a bent position. This leads to loss of flexibility, especially in rigid hammer toes. 5. Callus and cone formation. The bent toe abuses against footwear, leading to friction. This causes the development of corns, calceous, and skin irritation over the PIP joint. 6. Progression to rigidity. Over time, the deformity becomes fixed, the reversible without surgical correction. In severe or untreated cases, dislocation or subluxation of the joint may occur. This stepwise process shows how a minor muscle imbalance can gradually lead to a painful functioning limiting to deformity if not properly managed. Signs and symptoms. 1. Toe bend at the middle joint resembling a hammer. 2. Pain or irritation, especially with shoes. 3. Redness, inflammation or swelling. 4. Corns or calluses on the top of the toe or foot. 5. Difficulty walking or wearing shoes. 6. Restricted joint motion. 7. Toe rigidity in advanced stages. Diagnosis. Diagnosing is properly clinical. 1. Physical examination. Inspection and palpation of the affected toe. 2. Footwear assessment. 3. X-ray to determine the severity, joint involvement or deformity. 4. Neurological exam if underlying nerve disorders are suspected. 5. Gait analysis. Nursing diagnosis. 1. Acute pain related to joint deformity and friction. 2. Impaired physical mobility due to structural abnormality. 3. Disturbed body image related to visible deformity. 4. Risk for impaired skin integrity related to corns or ulcers. 5. Knowledge deficit regarding proper footwear or foot care. Medical management. 1. Footwear modification, roomy toe boxes, high heels, orthotic inserts. 2. Toe pads or splints, reduce friction and reposition toe. 3. Anti-inflammatory medications, NSAIDs for pain and swelling. 4. Corticosteroids injection for severe inflammation. 5. Physical therapy, toe stretching and strengthening. 6. Surgery for rigid deformity, tendon release, joint fusion, or recession, arthroplasty. Nursing management. 1. Education on foot hygiene and proper footwear. 2. Monitor for skin breakdown or ulcers. 3. Assist with pain management strategies. 4. Encourage adherence to stretching exercises. 5. Post-operative care of surgeries is done. Monitor wound healing. Administer analgesics. Reinforce non-weight bearing precaution as prescribed. Treatment options. 1. Non-surgical orthotic devices, toe spacers, splints, shoe modifications, stretching exercises, pain management. 2. Surgical tendon lengthening or transfer, joint recision, arthroplasty, joint fusion, arthrodesis, amputation, rare only in severe diabetic cases with infection. Psychosocial medicine. 1. Body image support, counseling to improve self-esteem and acceptance. 2. Support groups, peer interaction for emotional support and shared experiences. 3. Patient education, reducing anxiety through understanding the condition and treatment. 4. Anxiety reduction techniques, breathing exercises, mindfulness, and guided imagery. 5. Encouraging independence, promoting self-care routines, safe ambulation, and adaptive footwear use. Prevention. 1. Wear properly fitting shoes with ample toe space. To avoid prolonged wearing of high heels. 3. Perform regular toe and foot stretching exercises. 4. Inspect feet regularly, especially in diabetic individuals. 5. Use protective padding or orthotics if predisposed. 6. Addresses foot injury promptly. In conclusion, hammertoe is a progressive toe deformity that can significantly affect mobility and quality of life. If left untreated, early recognition, appropriate footwear, and conservative therapies can help manage the condition effectively. For rigid deformities, surgical correction provides long-term relief. Nursing or plays a vital role in education, skin care, and psychosocial support. Prevention is possible with simple lifestyle adjustment, especially proper footwear and regular foot care. Thank you. Have a nice day.